Now let's just talk about some general MSK pathology. There are much more common things than like Duchenne's muscular dystrophy. So we're going to talk about more common things, and we're going to talk about it systematically. So we'll talk about upper limb problems and then lower limb problems. We'll start with the upper limb, and again, very systematically, we'll start from the top down. So shoulders, elbows, wrist. Start with the shoulders. Your shoulders is this very lovely, very flexible ball and socket joint. Allows you a great range of motion, a lot of activity. And it is basically your humerus, your upper arm, attaching to a cavity in your scapula, or your glenoid cavity. So it's your humerus plus your scapula. That's what makes up your shoulder joint. Humerus plus scapula. Now there are muscles that come on and attach to your joint, the shoulder joint, and pull it different ways. And that helps us with our arm movement. And the muscles that come on and attach to your shoulder joint is going to be called your rotator cuff. It is literally a cuff of muscles that help your shoulder rotate. There are 4 muscles. And memory aid is sits. So S-I lowercase t s. And I'll tell you why it's lowercase t in a second. So S-I-T-S. The first S stands for Supraspinatus. That just means above the spine, and that's not the spine, your spinal cord. If you see a picture of your scapula has a little scapula spine. This is a muscle that goes above the scapula spine. So it's called supraspinatus, and this helps you abduct your arm. It goes above the spine and actually goes underneath the acromion process, and it kind of ducks and weaves through these bones. And because it does that, it's easily torn and damaged, and it's easily impinged just because it's kind of in a compromising position. It's kind of like weaving in and out of bone, so easily impinged. Now you got to know your physical exam when you're doing an MSK. So what are some physical exam tests if you're suspecting supraspinatus tear? Well, you can do your empty can test where you tell them turn your hand over and do this, and that kind of just further impinges your supraspinatus, and you'll press down, they'll feel that pain. You can do Hawking-Kennedy, where you place your elbow in and then you again press down, and that further impinges your supraspinatus. So Hawking-Kennedy and empty can. And yes, they do test physical exam findings. They might just say Hawking-Kennedy, not say anything more, and you should know supraspinatus. The next I stands for infraspinatus. Why do you think they call it infraspinatus? It sits below the scapular spine. So infraspinatus will laterally rotate your arm. Lateral rotation. Injuries are commonly seen in pitchers because they have to laterally rotate their arm. So pitchers. T stands for Teres Minor. The reason it's lowercase is because you have Teres Minor and Teres Major. And by making it lowercase, it just helps you reinforce the fact that it's Teres Minor. So Teres Minor, that's the T. Teres Minor will also laterally rotate. But it adds something else. It adducts. 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 And then last but not least, your last S is going to be your Subscapularis. Called that because it sits in the scapula fossa, so it's kind of underneath the scapula, almost. That's why I call it Subscapularis. It medially rotates and adducts. They might ask you what nerves innervate this. This isn't really our neuro talk, so I'm just going to go over it quickly. First 2 is going to be your suprascapular nerve. Your subscapularis is going to be your subscapular nerve. And then the odd man out is your teres minor, that's your axillary nerve. And that is your rotator cuff muscles. Now, without looking, because I'm going to try and cover the board, without looking, what rotator cuff muscle abducts your arm? If you said supraspinatus, you'd be right. But that's not the whole story when it comes to arm abduction. In fact, arm abduction is pretty complex. You you have different muscles that abduct your arm through a different range of motion. So your supraspinatus abducts your arm, that's absolutely correct, but it only abducts the first 15 degrees. So basically from here to here. Then your deltoids kick in. So delts kick in, abducts to 90 degrees or the horizontal. So from here to here. And the rest is your serratus. So from 90 up. So first 15, supraspinatus. 15 to 90, delts, and then 90 up, serratus. So I've seen a lot of questions where they say, patient cannot abduct your arm at all, so something's wrong with their supraspinatus. Or they'll say it abducts to 15 but it can't go higher, something's wrong with their delts. Or it goes to 90 but it can't go higher, something's wrong with their serratus. Understand, now serratus is innervated by the long thoracic nerve. Why do you think we call it the long thoracic nerve? In anatomy class, this gal was looking at this nerve and said, I always forget what this long thoracic nerve is called. And I just looked at her like, what? It's called a long thoracic nerve because it's a long thoracic nerve. And this nerve can get damaged by things like breast surgery. You can damage that nerve and then you won't be able to abduct your arm past the 90. Understand? Just a little aside, but very important. I've seen a few questions on it. Some other shoulder problems you can run into. Shoulder dislocation is common. Shoulder dislocation is just when your humerus just pops out of the joint. And you can have posterior where it pops back, inferior where it pops down, anterior where it pops forward. And anterior is the most common. And when it pops forward and pops out of the joint, it can actually damage nearby structures. So it can damage the nearby nerve, so axillary nerve. You kind of lose sensation on that area. It can damage things like the blood vessels, especially the posterior circumflex that runs around the area. And then your supraspinatus. Last shoulder pathology we're going to talk about is frozen shoulder, also known as adhesive capsulitis. This disorder is somewhat unknown. No one really knows what causes it, but there's inflammation of your shoulder joint. And it causes all these adhesions and makes your shoulder very stiff. And patients usually have periods where their shoulder gets so stiff they can't move it at all, and then somehow it just like self-resolves and they can move again. And then months later it'll start to stiffen, and then they can't move it, and then it'll relax. So it's very painful. And when you do an x-ray of your shoulder, you don't see anything. You don't see those adhesions. You're not going to see those adhesions. But if you inject dye into it called arthrogram, or you can do an arthroscope where you just basically scope and look at it, you'll see all those adhesions. What are some things we can do? Well, we can do NSAIDs, glucocorticoids, NSAIDs, glucose, and we can also tell them to mobilize. This is kind of counterintuitive when you feel your shoulder hurt and you don't want to mobilize it. But we realize that when you mobilize it, it kind of reduces that inflammation and helps it stop from freezing, basically. So mobilize. That's a good trick question, though. Talk about all these findings of frozen shoulder. Says the patient's starting to feel pain. What do? You mobilize, okay? Again, counterintuitive. Sometimes you want to like not move at all, but you gotta mobilize it. That's your shoulder. Let's move on to your elbow. So your elbow is your humerus connected to your radius and your ulna. So your humerus connected to your radius and your ulna. And at the end of your humerus, you have your medial epicondyles, lateral epicondyles. You can feel these at home, so just feel your humerus and then feel your medial epicondyle and then your lateral epicondyle. It's important because in adults you see something called epicondylitis, inflammation of these epicondyles. The medial one, I'm going to put this down for a second. The medial one, if you have constant flexion, you can have inflammation and pain of that medial epicondyle. So I'll say flexion, medial equals constant flexion, They say golfers get it a lot. I'm guessing because they golf and has that medial flexion. And then your lateral epicondyle, if you have constant extension, you kind of inflame that lateral epicondyle. So lateral epicondyle extension. It's commonly seen in tennis players because they do a lot of backstroke. So tennis. In layman's term, they call it tennis elbow or golfer's elbow. That's just inflammation of that epicondyle. Now that's in adults. What do kids get? Well, kids get something called Radiohead Dislocation or subluxation. Now what the heck is that? Well, there's a connective tissue that connects the radial bone to your ulnar bone. What do we call things that connect bone to bone? We call those ligaments. And this is called the annular ligament. Annular ligament. If there's some force that pulls the radius away, dislocates the radius, and that annular ligament can go in and slip between the humerus and the radius, and that causes a lot of pain. What can cause that? Well, common things is upward pulling of the arm. So if the child is holding onto the parent and then slips and falls, and you have that upward pulling, can dislocate that radius, or child abuse, sadly, or even just playing when you're just kind of holding your child by the arm and you're just playing with the child. So all that can dislocate that radius, that annular ligament slips in between, causes a lot of pain. The classical sign is the kid will have their arm extended. They don't want to flex it because if they flex it, it causes all that pain. So just have their arm extended like this. And the history will tell you about some sort of upward pulling. That is actually all I have to say about your elbow. Let's move on to your wrist. Now your wrist, the anatomical term for your wrist is carpus. Carpus. And the bones that make up your wrist, that make up your carpus, are your carpal bones. So your bones right over here, and there are 8 of them. There are 4 proximal bones, 4 distal. And if you look at them like this, then it's basically 4 on the bottom row, and then 4 on the top row. Makes it very easy. And you gotta know the bones of your carpus, your carpal bones. I've seen a lot of questions, they just show an x-ray of the bones and ask you to identify. That's one of the few simple, I guess, questions that's just basically anatomy questions. How do you memorize these? Well, there's a memory aid that I use that I found helpful. It's a phrase, it's so long to pinky. Here comes the thumb. So long to pinky, here comes the thumb. What the heck does that mean? Well, if we have our hand like this, and so this bottom row is going to be these bottom 4 bones, and this top row is going to be these top 4 bones. So long to pinky refers to the bottom bones, and it's called so long to pinky because you're going to be moving towards the pinky. Here comes the thumb refers to the top bones, and it's here comes the thumb because you're going to be moving towards the thumb. So long the pinky, S for scaphoid bone, L for lunate, T for triquestrum, P for pisiform. So again, it will be so long to pinky, or scaphoid, lunate, triquestrum, pisiform. That's your lower row. Now your top row is going to be here comes the thumb. So the H stands for hamate. The C stands for capitate. The first T stands for trapezoid. And the last T, trapezium. Here comes the thumb. Hamate, capitate, trapezoid, trapezium. And that's your carpal bones. Now there are some important things to know about these bones. For example, your scaphoid bone is the most easily fractured and most commonly fractured. The reason for that is if you fall on an outstretched hand, you kind of have a tendency to laterally rotate your hand. You can smash that scaphoid bone. Yeah, That's your first bone on the bottom row, so you can smash that bone. So it's one of the more easily fractured bone. And you can feel that pain right around your anatomical snuff box. That's where it is. All right, anatomical snuff box. Not only does it easily fracture, it doesn't heal well. Avascular necrosis, non-union of fracture. Why is that? Because this has retrograde blood supply. Recall our talk on retrograde. So if there's tissue and a blood vessel goes right to a tissue, that's normal, that's anterograde. If there's your tissue and your blood vessel goes past it and then comes back, that's retrograde. That extra complicated step just makes it a little bit worse. So because it's retrograde, it just doesn't get that blood supply, it doesn't heal well, you can get avascular necrosis, and it doesn't help that it's the most easily fractured. That's your scaphoid. If you fracture your lunate bone, lunate, so it'd be this one, you can compress a nerve that goes through your wrist called your median nerve. And that can cause carpal tunnel syndrome. We'll talk about that in a second. And then lastly, if you fracture your hamate bone, that'd be here. You can hit another nerve, the ulnar nerve. So those are your bones. Know the complications of if you fracture them. And also know that the memory aid works when you have your hand like this. Now, is this the anatomical position? No. Your anatomical position would be this, yeah? So if you use this memory aid, you also have to be comfortable if the hand is flipped. All right, so just be careful of that. Let's talk about the wrist in a little bit more detail. Your wrist have a ton of bones, has 8 bones in it. And it has a ton of muscle too. All the muscles in your hands coursing through your wrist. So your wrist is a crowded place. If you take a cross section of your wrist, it's just like jammed packed full of stuff. And it doesn't help that we have 2 major nerves that have to go through the wrist. What are those nerves? Be your median nerve and your ulnar nerve. Median and your ulnar. Your median nerve supplies your lateral first 3.5 fingers. So 3.5. And then your ulnar nerve supplies the last 1.5. 1.5. So it has to transverse that treacherous path through your wrist. But lucky for us, we have these little tunnels. That way these nerves can transverse freely. And we want them to transverse freely. We don't want to impinge them. If you impinge a nerve, it hurts, right? So we have these tunnels that let them go freely. The tunnel for the median nerve is called the carpal tunnel. Carpal meaning wrist, tunnel meaning tunnel, so a tunnel in your wrist. This tunnel can get crowded, it has a ton of tendons in there. You also have this giant ligament that wraps over it called the transverse ligament. So it's a very tight fit in there, okay? That's your median tunnel. Your ulnar tunnel is the Guyan tunnel. All right. What's the importance of this? Well, there's some sort of inflammation or mass effect on these tunnels, and it'll compress those nerves and you'll get that nerve pain. If you compress your carpal tunnel, you'll get carpal tunnel syndrome. And carpal tunnel syndrome is when your median nerve is compressed, and you'll have that nerve pain in the distribution of your median nerve. So your first 3.5 digits, you're gonna have numbness, you're gonna have pain. Also, this meaty, fleshy, thenar eminence, because it's no longer getting supplied because your median nerve is compressed, it's going to start to atrophy. So thenar, atrophy. Important to note, the sensation isn't affected as much because you have another collateral nerve that supplies it. So sensation for thenar is all right. Sensation, okay. But the rest, you get tingling, you get pain. If you flick it or tap it, they're gonna have that tingling, numbness, pain. Or if you flex the patient's wrist, compresses it further, causes that pain. Now, what can cause it in the first place? The most common cause is just repetitive movement or flexion. So people that work with their hands a lot, or people that type a lot, always have that flexion, can irritate that tunnel, can irritate that median nerve. That can cause it. Any type of inflammation or mass effect. Inflammation because it inflames your tunnel. Mass effect because it basically smushes your tunnel. So mass effect include things like obesity, pregnancy, hypothyroidism. That all just causes increased mass around your tunnel. Inflammation, rheumatoid arthritis, and also diabetes mellitus. This can basically cause nerve damage, and also if it's type 2 diabetes, then they can be overweight and cause mass effect that way. So those are all causes of it. What's the treatment? Well, you can modify the activity. If you're typing a lot, you can try to type less. You can do NSAIDs, kind of alleviate that pain. You can splint, so hold your wrist in place. That way you don't have repetitive flexion. So splint, and if all else fails, then you're gonna wanna cut that transverse ligament, kind of open up that space. We call that tunnel release. That's a fitting name, tunnel release. That is carpal tunnel syndrome. Guyan tunnel syndrome is when you have something compressing your Guyan tunnel, compressing your ulnar nerve. So you're gonna have all that numbness, all that pain, but it'll be on the distribution of your ulnar nerve, so your last 1.5 digit. Commonly seen in cyclists, they basically compress against their cycle bars and can compress that Guyan tunnel. I've seen a lot of students get this wrong because we get into, and I'm guilty of this also, we get into this one-track mind of things where we absolutely think it's something and we don't think about any other possibilities. So we hear about numbness and tingling in the hands and we always think carpal tunnel syndrome. Yeah, we're thinking carpal tunnel syndrome, even if the history is completely different, even if the numbness and tingling is on the last 1.5 digits, we're just thinking carpal tunnel. We're like, whoa, that's a weird way to ask carpal tunnel. No, it's not carpal tunnel, it's Guyan tunnel syndrome. Okay, so don't get caught up on that, and make sure you know that there are 2 tunnel syndromes. And if you know that, I think you'll do well. Hope you enjoyed this video. Thanks.